The blood vessels are the pipes or conduits of the cardiovascular system, and there are three types. Arteries carry blood away from the heart. They are going to branch or diverge or fork and separate into smaller and smaller vessels. Eventually, the smallest of the arteries will be the arterioles. The arterioles will feed the capillaries. The capillaries are where the exchange of oxygen and carbon dioxide and nutrients and waste will occur between the blood and the body tissues. The capillaries will feed into small veins called the venules. These will join or merge or converge until they become larger and larger vessels. The veins return blood to the heart. The blood vessel walls have three tunics or layers. The lumen of the blood vessel is the central opening. This is where the blood flows. The tunica intima is the inner lining of the blood vessel. This is the endothelium. It is a simple squamous epithelial layer. The function of the tunica intima is to reduce friction between the blood and the wall of the blood vessel. The tunica media is the middle layer. This is composed of smooth muscle. The smooth muscle is circularly arranged around the blood vessel. In some of the blood vessels, there are sheets of elastin. The muscle activity is regulated by the vasomotor fibers of the sympathetic nervous system. This means that the muscles can contract. This is called vasoconstriction, and this narrows the lumen, or the vessels can dilate. When the muscles relax, the lumen opens up. The outermost layer of the blood vessels is the tunica externa, or the tunica adventitia. This is composed of connective tissue. Primarily, it's loosely woven collagen. It provides protection for the blood vessel and helps anchor the blood vessel to nearby tissues. The blood vessels themselves are composed of different layers. The arteries have all three layers. They have a tunica intima, they have a very thick tunica media, and in some of the blood vessels we have a lot of elastin sheets, and then they have the outer tunica adventitia. The capillaries are composed only of the tunica intima, the single layer of cells. The veins also have a tunica intima. They have a tunica media, which is relatively thin, and a tunica adventitia. One other thing we find in the veins are valves. So as we look at the arteries and the veins, everybody has the inner layer of tunica intima, and that's all that the capillaries have, these endothelial cells. And the endothelial cells do have to be on a basement membrane. Then we see the relatively thick tunica media of the artery, the thinner tunica media of the vein. Notice how the arteries have these elastin sheets that the veins do not have. And then we have the tunica adventitia. So the arteries feed the arterioles, which feed the capillaries. The capillaries will drain into the venules, which will go into the veins. Blood from the heart, blood back to the heart. Notice here are the valves in the veins. The arterial system has two kinds of arteries, elastic arteries and muscular arteries. The elastic arteries are those arteries that are closest to the heart, the aorta and the major branches from the aorta. These are the largest of the arteries and the most elastic. They have the most elastin in them. These arteries act as pressure reservoirs. They help make the pressure in the vessels more constant. When the heart contracts, there's a big thrust of pressure that comes into these blood vessels. They're going to expand and then recoil. That does two things. One, it keeps the blood flowing. It's sort of that expansion and rebound. They have sort of an auxiliary pump. But also it sort of damps down the pressure a little bit. So as the blood leaves these elastic arteries, there's a more constant pressure rather than this rebound and alternating pressure. Because these vessels have more elastin in them, they're relatively inactive in vasoconstriction. These are more like elastic tubes. Their function is to protect the other arteries from excessive pressure. Excessive pressure in the other arteries could cause tears or ruptures in them. One of the things that excessive arterial pressure would eventually lead to would be a weakening of the artery walls. Then they would balloon out. This would be an aneurysm. The problem with aneurysms is there is less supporting tissue around them, and so under high blood pressure, they may burst. Blood would then freely flow from the artery. The muscular arteries are sometimes referred to as the distributing arteries. These are the arteries that deliver blood to specific organs. They account for most of the named arteries in the body. The lumen of a muscular artery may be as large as your little finger to as small as the lead of a pencil. They have relatively more muscle. They have the thickest tunica media, and they're the most active in vasoconstriction. They're much less stretchy than the elastic arteries. The arterioles are the smallest of the arteries. These arteries begin to lose their tunica media. The muscle, instead of being a solid wall, tends to be a spiral around the vessel. The arterioles are what are going to control the blood flow to the capillaries. The diameter of the arteriole varies based on neural stimulation and chemical stimuli in the tissues. The arterioles are the vessels that deliver blood to the capillary beds. Here we can see the difference between the elastic artery with its elastic sheets and a good-sized tunica media, but not as thick as the muscular arteries. And here in the arteriole, you see how the layer of muscle begins to diminish to more or less single muscle cells wrapped around the artery. The capillaries are the smallest of the blood vessels. They're microscopic, and they only have a tunica intima. This is where exchange will occur between the blood and the tissues. Most tissues have a rich capillary supply, but there are some exceptions. Tendons and ligaments have a very poor capillary supply. That's why they heal so poorly. Cartilage and epithelial do not have their own capillary supply, but they do have nearby tissues that have a rich blood supply. Nutrients diffuse from those into these areas. And the cornea and the lens are avascular. Otherwise, you'd see cobwebby things when you look through your eye. They're nourished by the aqueous humor. There are three types of capillaries: continuous, fenestrated, and sinusoidal. All capillaries have tight junctions that join the endothelial cells. You'll remember that tight junctions were sort of like a Ziploc bag. However, these tight junctions are usually incomplete, so it's sort of like a Ziploc bag that doesn't close completely. This leaves spaces between the cells that are called intercellular clefts. These intercellular clefts allow for some passage of fluids between the blood and the tissue. Capillaries go to virtually every cell in the body. The continuous capillaries are the most common. They're abundant in the skin, the muscles, the lungs, and the central nervous system. They often have cells associated with them called pericytes. Pericytes are kind of spider-shaped and they're contractile. They're stem cells. They can either generate new vessels or they can generate scar tissue. They help stabilize the capillary wall and help control capillary permeability. Now here you see a continuous capillary. The endothelial cells are pretty tightly fit together. This blue here is the basement membrane that all epithelial cells have to sit on. Tight junctions, but then some places where the junction is not so tight. Here is a pericyte. Here's another pericyte. These are surrounding the capillary, giving it some support. Fenestrated capillaries are a lot like continuous capillaries, but some of the cells are riddled with pores. The cells sort of look like Swiss cheese. These capillaries are more permeable, and they're found in areas where we need a maximum exchange of materials. For example, in the intestines where we absorb food, or in the endocrine glands where secretions need to be picked up, and in the kidneys where filtration of urine occurs. Fenestrated capillaries have the same fairly close junctions with some intercellular clefts, but notice how the cells have these holes in them. These are the fenestrations. Sinusoidal capillaries, or sinusoids, are the most permeable of the capillaries. These have large irregular lumens, and they're usually fenestrated. There are much larger intercellular clefts. This allows for the passage of larger molecules. Also, blood flow in the sinusoidal capillaries is exceptionally sluggish. We find sinusoidal capillaries in the liver, the bone marrow, and the spleen. And you can see huge fenestrations, enormous intercellular clefts. The whole capillary sort of looks blown out. Capillary beds make up the microcirculation of the circulatory system. It's the capillary beds that feed the individual cells. A capillary bed is just an interweaving of capillaries. Capillaries branch and rejoin. A terminal arteriole will lead to a blood vessel called the metarteriole. The metarteriole is continuous with the thoroughfare shunt. The thoroughfare shunt goes directly between the arteriole and the postcapillary venule. The true capillaries, 10 to 100 per tissue, will branch from this thoroughfare shunt. Blood flow in the capillaries is controlled by the precapillary sphincter muscles. So here we see a capillary bed. This would be your terminal arteriole. Here is the metarteriole and the thoroughfare shunt. And here is your postcapillary venule. Here are the true capillaries that branch off the metarteriole and the thoroughfare shunt. If the tissue is needy, if blood needs to flow to all of the cells, these sphincter muscles are open, allowing blood into the capillary bed. If the tissue is not particularly needy, the sphincter muscles will close. Blood supply will not go into the true capillaries, and the blood will go directly from the arteriole to the venule. Think about your calf muscle. If you're walking around, climbing stairs, that muscle tissue is very, very needy. You would have this kind of blood supply to it. But at night when you're sleeping and that muscle is relaxed, you would not need quite as much blood supply going to every cell of that muscle, and so more of the blood would take the interstate through that tissue rather than all of the back roads. The venous system returns blood to the heart. The venules begin to increase in tunica media as the vessel size increases, and the venules merge to join veins. The veins will have all three tunics. Veins will have a thinner tunica media and pretty much no elastin. They also have a larger lumen. They do have a thicker tunica adventitia to give them more support. Now the veins will accommodate large volumes of blood, and for this reason they are sometimes called capacitance vessels and blood reservoirs. They do have valves in them to prevent backflow. If you think about it, most of the blood has to fight gravity to get back to the heart. Varicose veins and hemorrhoids occur when there are incompetent venous valves. The valves break down and the blood pools. The veins dilate and become tortuous or twisted. Some contributing factors for varicose veins include heredity, this does tend to run in families, and conditions that hinder venous return, for example, prolonged standing or pressure on the groin vessels. Pregnant women have trouble with varicose veins because as the uterus expands, it tends to put pressure on the groin vessels, preventing adequate blood flow. People who are overweight have much the same problem. Blood pools in these lower limbs, the valves weaken, the venous walls stretch, and since this primarily happens in the vessels that are called the superficial vessels, they have less support, so you tend to see the damage in the superficial vessels. Hemorrhoids are simply varicose veins of the rectum. Venous sinuses are highly specialized flattened veins. They have extremely thin walls, basically only the endothelium. They're supported by the tissues that surround them. Venous sinuses pool capillary blood before sending it to veins. You see this in the coronary sinus, also the dural sinus in the brain. Vascular anastomoses are simply special blood vessel interconnections. Arterial anastomoses occur because organs receive blood from more than one arterial branch. This provides alternate pathways for arterial blood to get to the organ. We call this collateral circulation. An example of this can be seen in the joints. As you move a joint, you may crimp one arterial supply a little bit and not get full flow to a joint. Because there are alternate arterial supplies to the joint gets plenty of arterial blood. Anastomoses are very common in abdominal organs, the heart, and the brain. Anastomoses and collateral circulation is important because it prevents interruption of blood flow, and there's minimal organ damage if that blood flow interruption should occur. Arteriovenous anastomoses, anastomoses between an artery and vein, occur at the medarterial shunt. And venous anastomoses, anastomoses vein to vein, are very common. You can just look at the back of your hand and see the interweaving of veins on the back of your hand. An occluded vein rarely blocks blood flow to any part of your body or leads to any kind of tissue death. Blood flow is necessary to sustain life. The heart is the pump, the arteries and veins are the conduits, and the capillaries are the exchange sites of the circulatory system. Blood is going to flow along a pressure gradient, from higher pressure to lower pressure. Blood pressure is necessary for blood flow, and resistance is necessary for blood pressure. Blood flow is defined as blood flowing through a vessel, an organ, or the entire system, and it's measured in milliliters per minute. If we talk about blood flow in the entire circulatory system, that's basically the cardiac output, or a little over 5,000 milliliters per minute. At rest, our blood flow throughout the system is relatively constant, but blood flow to individual organs can vary widely at any given time depending upon the needs of the organ. Blood pressure is the force per unit area exerted on a vessel wall by the contained blood, and it's expressed in millimeters of mercury. Unless otherwise specified, when we talk about blood pressure, it's the systemic arterial pressure in the largest vessels nearest the heart. The pressure gradient is the differences in blood pressure in the vascular system, and it's the driving force that keeps blood moving. Resistance is the opposition to blood flow. This is a measure of the friction between the blood and the blood vessels. Most of the resistance is in the peripheral vessels, so when we talk about resistance, we're typically talking about peripheral resistance. There are basically three sources of peripheral resistance. One is blood viscosity, how thick the blood is. Now this is fairly constant, and this is a direct variable. The thicker the blood, the higher the blood pressure. The total blood vessel length is another thing that contributes to resistance. Again, this is fairly constant, and this is a direct variable. The longer the blood vessel length, the higher the blood pressure. Blood vessel diameter is the only real variable there is. We can control the diameter of the blood vessels moment to moment, and this resistance is inverse. That is, as the blood vessel gets smaller, the blood pressure gets higher. The heart is the pump of the circulatory system, and it's what generates blood flow. The pressure is due to resistance to flow, which, as we have said, is the result of blood viscosity, blood vessel length, and blood vessel diameter. Blood is going to flow along the pressure gradient. The highest pressure is in the arteries near the heart. Pressure decreases as we move through the circulatory pathway, and the pressure is lowest in the right atrium. Arterial blood pressure reflects the compliance of the vessel. The compliance of the vessel has to do with the stretch of the elastic arteries. That stretch is important to help push the blood along after the heart has pushed it out into the vessels. Arterial pressure also reflects the volume of blood entering the arteries. Ventricular systole is going to provide the systolic pressure. This is blood at its maximum pressure, and normally that's around 120 millimeters of mercury. The elastic arteries stretch and sort of dissipate that pressure a little bit and help even it out as it moves into the muscular arteries. Ventricular diastole, when the ventricles relax, will give us our diastolic pressure. Here the semilunar valves are closed to prevent backflow, and the elastic arteries recoil. These act as pressure reservoirs as well as auxiliary pumps. This is the lowest pressure of the blood against the artery walls, and this is about 80 millimeters of mercury. Your pulse pressure is the difference between the systolic and the diastolic pressure. Now your pulse is felt as that throbbing of blood vessels. If a normal blood pressure is 120 over 80, that's systolic over diastolic, then the pulse pressure would be calculated by subtracting 80 from 120, which would give you a pulse pressure of 40. Your pulse pressure indicates how elastic the arteries are. The higher the pulse pressure, the less elasticity there are in the vessels. This means there has been a loss of auxiliary pumping power. The heart has to pump harder to keep the blood flowing. Now, there will be temporary increases in pulse pressure due to increased stroke volume from things like exercise, But if the pulse pressure is high chronically, that's an indicator of atherosclerosis. And atherosclerosis is the loss of elasticity of the blood vessels. It can be caused as a result of plaque forming on the inside of the blood vessels, scar tissue in the layers of the blood vessel wall, or calcifications of the blood vessel. Aortic pressure fluctuates with each heartbeat, and so it's important that we have sort of a steady pressure in the arteries. So this average pressure in the arteries is the mean arterial pressure. That's literally what mean means. It means average. This is the pressure that actually propels the blood to the tissues. To determine the mean arterial pressure, you take the diastolic pressure and you add to it 1/3 of the pulse pressure. So if our normal blood pressure is 120/80, our pulse pressure would be 40, and the mean arterial pressure would be the diastolic pressure of 80 plus 1/3 of the pulse pressure. And 1/3 of 40 is 13 1/3, so we'll just round that to 13. So 80 plus 13 is 93. As we've said before, blood flows on a pressure gradient. It's highest in the aorta because of ventricular systole, and it's lowest in the right atrium so that blood will flow back to the heart. As blood flows through the system, the force declines. At the beginning of the capillary bed, by the time it's gone through all the arteries, it's down from that 93 mean arterial pressure to about 35 millimeters of mercury. As the blood goes through the capillary bed, it loses even more pressure. At the end of the capillary bed, it's down to about 17 millimeters of mercury. This low pressure helps prevent damage to the capillaries. Remember, they're only one cell layer thick. It also allows for a slower blood flow so that exchange can occur. The venous pressure is steady, not pulsing. And at the venule, the pressure is about 15 millimeters of mercury. In the right atrium, it's 0 millimeters of mercury. That means there's a gradient difference of 15 millimeters of mercury. That's not enough pressure difference to ensure adequate venous return of blood to the heart. So we have to have some assists in the venous system. The muscular pump helps return blood to the heart. The respiratory pump helps return blood to the heart. And sympathetic vasoconstriction also helps. In the lower parts of your body, the veins are closely associated with skeletal muscle. As the skeletal muscle contracts and bulges, it's going to press on the veins and help force blood upward. Now, it's going to go upward because we have these one-way valves that will allow the blood only to go one way and not go backwards. This is why standing can give you varicose veins. If you're standing, your leg muscles are not contracting, and so the blood is just sitting in the veins. And as it sits on top of these valves, it can cause them to break down, and it can cause these veins to stretch out. The respiratory pump is sort of like sucking on a straw. As you breathe, your diaphragm acts as a barrier between the abdominal cavity and the thoracic cavity. So as you change the pressure here in your thoracic cavity breathing, you sort of suck blood up the vena cava, and that helps it return back to the heart. Deep breathing will increase venous return. And then the sympathetic nerves go to the smooth muscle in the blood vessels. If the sympathetic system is triggered, these smooth muscles will contract, and that will cause blood to be forced out of these reservoirs of blood and back into regular circulation. To monitor the circulatory efficiency, you can take the pulse and the blood pressure. The pulse is the expansion and recoil of an artery and represents one heartbeat. Now, you have to find pressure points, areas where an artery is close to the surface and can be palpated or felt. You want to compress the artery against a firm underlying tissue so you can feel the pulsing. This is an easy way to monitor and assess the effects of activity. More activity, pulse increases. Postural changes, as you go from lying down to sitting to standing up, your pulse will increase. And emotions. Strong emotions tend to cause your pulse to increase. The common pressure points are the superficial temporal artery, the facial artery, the common carotid artery, the brachial artery, the radial artery, the femoral artery here in the groin, the popliteal artery behind the knee, the posterior tibialis artery, which is sort of behind your ankle, and the dorsalis pedis, which is across the top of your foot. The radial artery is the most common pulse point, and of course, typically, if you're assessing someone to see if they have a heartbeat, you check their common carotid before you start CPR. Blood pressure is done using the auscultatory method. This is the method of listening. You need a sphygmomanometer and a stethoscope. Sphygmomanometer is the official word for blood pressure cuff. You're going to use the cuff to completely compress the brachial artery. That's why this part is a little bit uncomfortable. Then you will listen to the brachial artery with a stethoscope for the blood flow in the artery. As the sphygmomanometer releases pressure, blood will begin to force itself through the brachial artery. You're listening for the sounds of carot cough. The first sound is the first blood that can get through the compressed artery. That's going to represent your highest pressure or your systolic pressure. You continue listening until you hear the last sound. The last sound is the last time that the blood has to hit against the artery as a result of the artery being compressed. This is your diastolic pressure. Normally, your systolic should be somewhere between 110 and 140 millimeters of mercury, and your diastolic between 70 and 80 millimeters of mercury.